Hello, my name is Dr. Stephen Rush from the University of Cincinnati. Thank you for joining me today to discuss the crossroads of autoimmune encephalitis and psychiatry. What we often don't realize about autoimmune encephalitis is that psychiatric symptoms are not only present, but they are common, especially in the early phases of the disease. Clearly, the most studied of these is N-methyl-D-aspartate acid receptor encephalitis, or NMDA receptor encephalitis. However, we have seen psychiatric symptoms manifest with AMPAR receptor encephalitis and GABA-B receptor encephalitis. Our knowledge base in general around autoimmune encephalitis and NMDA receptor encephalitis specifically remains young, as the first case of this didn't appear in the literature until 2007. The information on this slide will show you that not only are psychiatric symptoms common in patients with autoimmune encephalitis, but they actually result in hospitalization in a psychiatric unit 60% of the time. In early stages of autoimmune encephalitis, we can see behavioral symptoms in up to 49% of cases, and psychosis in up to 17% of cases. Cognitive symptoms are also present, usually following under the purview of a psychiatrist, sometimes a neurologist, 6% of the times. So we can see that in terms of early symptoms, psychiatric symptoms represent the number 1 and the number 3. At any time during the course of autoimmune encephalitis, behavioral symptoms have been present in up to 80% of patients. Psychosis occurs in up to 44% of patients. So what do I mean when I say behavioral symptoms? If we think about behavioral symptoms in terms of what we see on the outside, this can include agitation, disorganized behaviors, and pathological laughter or smiling. Disorganized behavior can sometimes include the way that a patient communicates with someone. So disorganized speech can also be a component of that. And this basically means that what somebody is communicating or the behaviors that they are enacting are illogical, they don't make sense, and they are not appropriate to the situation that they are in. Psychotic symptoms, again, can present in up to 44% of patients, and in some literature as high as 67% of patients. These include things often seen in other psychiatric illnesses, including auditory hallucinations, visual hallucinations, and paranoid delusions. Mood symptoms are another very prominent psychiatric issue with autoimmune encephalitis, with almost 50% of patients at some point experiencing anxiety or panic, mood instability with irritability, which can, again, manifest in the behavioral symptom of agitation, mania, which is otherwise a component of bipolar illness or depression. Catatonic symptoms can also be prominent in autoimmune encephalitis and actually occur in up to 30% of patients. These symptoms include mutism or lack of speech, stupor or lack of engagement with the external environment, posturing and catalepsy, which are the maintaining of a posture that is against gravity, abnormal, and otherwise would be uncomfortable, sometimes for hours at a time. Verbigeration is also common, and this is a situation in which a patient will often repeat a sentence or a word over and over without it necessarily being relevant to any conversation being had. Echolalia is also sometimes a feature of catatonia. Echolalia is when a patient will, when they are speaking, only repeat the words that are being said to them. And then waxy flexibility is more of a motor or neurologic symptom of catatonia, and that is when passively moving a patient's arm as the physician, it might feel as though I'm moving their limbs through wax. It kind of has this soft resistance that makes it feel as though I'm moving a wax model. Sleep symptoms occur in up to 21% of patients, and they include a wide variety of issues that range from insomnia to hypersomnia, sleeping too little or sleeping too much, and then sleep-wake reversal or sleep cycle reversal, in which the patients are sleeping during the day and awake all night. The difficult thing about sleep-wake reversal is that it can then switch from sleeping all day and being awake at night to suddenly sleeping all night and being awake all day. This can also then morph into other problems with sleep. Someone may start with a sleep-wake reversal problem and then suddenly go into a state of insomnia and then revert into a sleep-wake reversal cycle and then have a period of hypersomnia where they're sleeping up to 21 hours per day. So there isn't any particular pattern of sleep disruptions, and oftentimes patients will cycle through a variety of these. Night terrors are most common outside of this patient population in children and are experienced from an observer's perspective as someone seemingly waking up from a nightmare. Lots of screaming, lots of terror, and lots of panic, although nobody can remember what they were dreaming about or what was causing that screaming or panic when they are waking up. So what is the commonly observed course of psychiatric symptoms in autoimmune encephalitis? I would preface this by saying that not everybody follows this course, and that of the stages I'm going to discuss, that people often move between stages in varying orders. There is definitely a prodromal phase that will always happen first. Prodromal phases in most psychiatric illnesses are very nonspecific. They are not significant enough to be able to make a diagnosis, and in this case would include cold or viral illness like symptoms such as fever, headache, fatigue, and those kinds of prodromal symptoms have been described in up to 70% of cases. Following the prodromal phases, in the early stages of autoimmune encephalitis, there often is then a psychotic phase, which happens about 2 weeks after that prodrome. This can include emotional disturbances that range from apathy and complete lack of emotion to depression and anxiety. Cognitive symptoms are also common, with deficits seen in executive function and working memory. An example of this deficit would be in the day and age of smartphones, suddenly not remembering how to use your phone that you had previously been very adept at using. Prominent schizophrenia-like symptoms are often seen in autoimmune encephalitis, and in some literature, it is estimated that up to 75% of patients with this illness are first diagnosed with schizophrenia. And that is because the symptoms are so close to what one would see in that diagnosis of schizophrenia that you really cannot tell them apart. This includes disorganized thinking, which is manifested by illogical speech and illogical behavior, compulsive action, delusions, often paranoid, hallucinations, which would include auditory hallucinations, hearing people talk or hearing things when there is no stimuli making that noise, and visual hallucinations. Another common symptom that is similar to schizophrenia is the loss of awareness of the self. And sometimes this progresses to something called anosognosia, or lack of insight into the illness, such that the patient isn't aware that there is anything wrong with them at all. Amnesia can often occur during the psychotic phase of autoimmune encephalitis, although it's not usually prominent at the onset. And then strange behaviors are also relatively common. For example, smiling inappropriately, laughing inappropriately and out of context, or staring at one's reflection in the mirror with a bizarre, inappropriate smile is not uncommon. Next, we should discuss the unresponsive phase. And this is where the symptoms of catatonia that I discussed earlier can come into play. Catatonia-like symptoms can include lack of speech or mutism, akinesis, which is a complete lack of movement or decreased lack of movement. And oftentimes, patients will be unresponsive to verbal commands while looking at a person, sitting in a maintained posture with their eyes open. During this stage, we can often see bizarre and inappropriate smiling. It may appear that somebody is very engaged in their internal world and responding through laughter or smiling to that internal world, which as outsiders, we are not privy to and just observe as laughter or smiling that is out of context. Athetoid dystonic postures are not uncommon in an unresponsive phase. This is a disorder of movement, maintaining bizarre postures with athetoid movements that, again, would be out of context to the situation. Not that we should really ever be seeing athetoid movements or dystonic movements in a healthy state, but they don't serve any purpose, and they oftentimes are a limitation in terms of someone's functioning. Another motor symptom or cognitive symptom, a combination of both, I guess, would be the echo phenomenon. And this is what I had discussed previously in catatonic symptoms and referred to as echolalia. This is, however, when somebody will mimic the observer's movements, also referred to as echopraxia. So patients may mimic what you say the same words back to you word for word, or you may be sitting across from them and they may be making each movement that you make in the same time. Interestingly, because we're talking about a neurologic disorder, at this stage in the illness, there are normal brain stimuluses, which are often reflexes that we check early on in a neurologic exam to make sure that the brain is functioning normally. However, there is one exception, and that is there is no eye movement with visual threat. This is a reflex that normally would have somebody moving their head or blinking their eyes when faced with something coming into their face or coming near their eyes. So this is the one brainstem reflex that is absent. As opposed to being akinetic or having very little movement in the previous phase, the hyperkinetic phase is marked by excessive movements. Almost all patients gradually develop what we call orolingual dyskinesias. And this would include lip smacking or the appearance that they're chewing something, although there's nothing in their mouth. And again, athetoid dystonic postures of the fingers. So this is bizarre movements. Dystonic would imply that they are held for some period of time, and again, manifest in the hands. We can also see intractable, bizarre orofacial limb dyskinesias. Oro implies that the mouth is involved, facial, obviously the face, and limb refers to the arms and legs. So this might include sustained jaw movements, constant forceful clenching of the teeth, a jaw opening dystonia where somebody may open their mouth for a period of time that may be very brief before being able to close it again, grimacing, which is very similar to inappropriate smiling, intermittent gaze deviation or disconjugation, in which somebody's eyes are not focused on the same point in space and seem to be looking at different areas. A lot of times you can see dance-like movements in the arms in the case of intractable limb dyskinesias. These movements are often variable in speed, distribution. There isn't a specific pattern in terms of which hand, which arm, which leg seems to demonstrate symptoms like this. And the motor pattern can often be variable in the sense that it does not happen in a predictable sequence. This can often be confused with what is caused a psychogenic movement disorder, one in which a primary psychiatric illness, such as anxiety, is causing a physical symptom which might appear not to be psychiatric in nature, but actually is a manifestation of psychological distress. In the hyperkinetic phase, we can also see autonomic instability. Patients' blood pressures may be up and down and unpredictable. Heart rates can be slow or elevated. Temperature can be high, and oftentimes we can see patients begin to have periods of diaphoresis or excessive sweating. The thing that's difficult about treatment of psychiatric symptoms in patients with autoimmune encephalitis is that the typical treatments used for an illness that presents like schizophrenia, which I can say happens again in 75% of patients. Many of the patients that I have treated with autoimmune encephalitis, I initially felt certain had schizophrenia. And it was only with time and lab testing and involvement of other specialties that I came to understand this is not schizophrenia. However, the symptoms can be similar. They can be exactly the same. Patients can have auditory hallucinations and visual hallucinations. They can have paranoid delusions. And in a typical case of schizophrenia, we would use antipsychotic agents or medications to treat these symptoms. In the literature, oftentimes older antipsychotics are used to treat agitation, referred to here as conventional antipsychotics, and include Haldol and Thorazine. And then atypical antipsychotics are often used to try to treat the symptoms I had discussed previously, including hallucinations and delusions. Here is just a short list of some of the atypical antipsychotics used in the literature. In extreme cases, agitation and psychotic symptoms have to be treated with a medically induced coma using something like fentanyl or phenobarbital. The most difficult thing about psychosis in these patients is that those antipsychotics that we may use in schizophrenia or bipolar disorder with psychosis can often cause side effects that we see in other populations, but not as often. So these patients are especially susceptible to the movement side effects called extrapyramidal symptoms of antipsychotic medications. And those include akathisia, or an internal sense of restlessness that can be manifested by pacing around or constantly having to move. Often Parkinsonian-like symptoms, which might be a tremor in the hand, that's called a pill rolling tremor, a shuffling gait, a lack of expression in the face, and sometimes dystonic reactions, where a patient's muscle group locks in a position. Very commonly, we refer to a locked gaze deviation as an oculogyric crisis, one in which the patient's eyes are literally stuck in a position that they cannot move them from. And that is a good example of a dystonic reaction that is not uncommon in autoimmune encephalitis. The issue outside of the higher likelihood of having side effects from these agents is that atypical antipsychotics, again, the newer group of antipsychotics, while we still try to target psychotic symptoms with them, we really don't have a lot of success. Oftentimes, we end up going to a medication called clozapine. Clozapine is specifically good for this population because it has properties that help us avoid those movement disorders that we often see with other medications, and may have some action on the NMDA receptor in terms of NMDA receptor encephalitis. This comes with varying success, but is oftentimes a medication that is used as a last resort in other patients, and in this patient population may be done earlier on. Insomnia, again, referring back to the sleep disorders in autoimmune encephalitis, insomnia is treated similarly to the way we would with other cases of insomnia secondary to psychiatric illnesses. So the use of melatonin 4 to 5 hours before bedtime, clonidine, which initially was used for blood pressure, trazodone, which is an antidepressant with strong antihistamine properties, and then benzodiazepines. Some familiar names of benzodiazepines may include Ativan, Klonopin, Valium, or Xanax. One other medication sometimes used for insomnia is gabapentin. Of these medications that I discussed, benzodiazepines, clonidine, and trazodone have proved to be the most successful in addressing difficulties with sleep initiation and continuity. That is, they are best able to help patients get asleep, stay asleep, and continue to have a regular sleep cycle. Oftentimes, catatonia is treated with benzodiazepines as well. And so in the case of someone who's catatonic, benzodiazepines may not work well to help someone sleep because it's actually a medication that's keeping them out of that stuporous-like state. Sometimes psychiatric symptoms end up treated with electroconvulsive therapy, which for many people is a very frightening word, which oftentimes stems back to the movie One Flew Over the Cuckoo's Nest, in which a very barbaric procedure was presented to the audience in that movie. Electroconvulsive therapy today is a very humane procedure. It is done with anesthesiologists. It is done with as minimal electricity as possible. And the short and sweet version of what ECT or electroconvulsive therapy is applying an electrical impulse across the brain such that a seizure is induced. These seizures often kick patients out of varying states of illness, from depression to mania and bipolar disorder, and sometimes catatonia. So what is the role of the psychiatrist? Why am I here talking to you about this? If you'll remember that 60% of patients have psychiatric symptoms and are admitted to a psychiatric hospital early on in the course of their disease, and that up to 75% of patients are diagnosed with schizophrenia, the role of the psychiatrist may actually be that of the first responder in the case of autoimmune encephalitis. Personally, having gotten to work with a number of these patients, I view my role as that first contact whose job it is to make sure that what I'm looking at is schizophrenia, for example, and that I'm ruling out autoimmune encephalitis as a possible cause of those symptoms. And this is crucial because the longer the delay in diagnosis, the longer the delay in treatment, and the worse the outcomes in terms of having somebody who is able to return to their pre-disease state. So making the diagnosis early on and referring to a neurological colleague is something that would be very important for me to do. Otherwise, my role is often supportive. I prescribe medications to manage the psychiatric symptoms that are present, knowing that it really is the treatments by neurologists that are going to ultimately treat the autoimmune encephalitis. While those symptoms are present, it is important to treat them. Psychotic symptoms, for example, psychosis is a neurotoxic state. It is toxic to the brain. It is important to treat psychosis anytime that it is present. And similarly, certain mood states can be toxic to the brain. Manic-like states where somebody isn't sleeping and talking a lot and their mood is going from euphoric to really angry. Often seen in bipolar disorder, mania can also be seen in autoimmune encephalitis and is known to be a toxic state to the brain. So oftentimes it is a challenge to understand as a family member or even as a patient why psychiatrists are involved prescribing psychiatric medications for a disease that is neurologic. And the short and sweet answer is we are doing that in a supportive role to prevent these toxic states from making anyone's condition any worse. Here are some references that I've had if you're interested in looking up more information. And thank you for your time.